As a veterinary profession, we can have a tendency to be a little bit wishy-washy in our recommendations, that sometimes we're just listing all of the options for them. But realistically, I feel like we need to kind of put on our surgeon pants a little bit sometimes and pretend to be a surgeon. Put that hat on and walk in the room like you are that confident surgeon who's going to go in there and say, I recommend this.
Hey, VetFolio Voice friends, it's Dr. Cassie. Welcome back. This episode is sponsored by Zoetis, and for this episode, I was joined by Dr. Michaela Mayland. We talked about osteoarthritis and orthopedic exams in dogs. So we dive into the orthopedic exam and what it really looks like in general practice. And I loved that Dr. Mayland shared her experience doing relief work in general practice and the influence that had on shaping her perspective on just how hard it can be to perform an orthopedic exam consistently, on every patient in practice. There's so much to address in a typical appointment that one of the big takeaways I think we landed on was that even though once we're comfortable with that orthopedic exam, it can be done fairly quickly, it may not be realistic to focus on performing an orthopedic exam on every single patient. Instead, we talked about shifting the focus away from performing the orthopedic exam on every single patient who's getting a full exam to identifying which patients really need it most, to effectively screen these patients and recognize them so we're not missing opportunities to diagnose and treat joint pain. We also spent time talking about management options for osteoarthritis and how to approach these conversations with pet owners, especially in those early stages where the signs may be really subtle. I think we've all heard that classic line of, he's not in pain, he's just slowing down, he's getting older. But the reality is that most dogs, they don't have a slow down mode. They don't know how to slow down. And they certainly shouldn't be doing that, in their younger years in most cases. So with the right plan, consistent follow-up, good communication, we can help support mobility and quality of life over the much longer term for these patients. Let me tell you about Dr. Mayland, and we will get into it. Dr. Michaela Mayland grew up in Colorado and has trained across the country, earning her degree in biology and anthrozoology, that's a cool degree, from Carroll College before completing her DVM at the University of Minnesota. During veterinary school, she held leadership roles with the Veterinary Business Management Association and served as president of the student chapter of the American Association of Equine Practitioners. She went on to complete a rotating internship in Los Angeles, followed by a surgical oncology internship at the University of Missouri, and then a surgical residency at Cornell University. Her research spans topics from surgical oncology techniques to residency demographics. After residency, she worked as a staff surgeon at Alameda East Veterinary Hospital and now serves on the Zoetis specialist team. She lives in Colorado with her husband, 3 horses, 3 cats, and her Labrador Retriever Denali. All right, let's go ahead and get into our episode.
Pet parents are looking for a veterinary practitioner who can prove they understand and support the relationship they have with their pet, show you value your client's trust, and earn an official Human-Animal Bond certification from NAVC and HABRI, the Human-Animal Bond Research Institute. This certification, appropriate for all members of the healthcare team, explores the scientific benefits for veterinary staff, owners, and animals, and discusses how to establish and promote a strong human-animal bond. Enroll today at vetfolio.com.
All right, I'm joined by Dr. Michaela Mayland, and we're going to talk about canine pain. And I love kind of the overarching idea of talking about canine pain because it exists in so many different contexts. And so, I think it bears a broad conversation, and I'm excited to get into it. Thank you for being here.
Yeah, thank you for having me.
Yes, happy to have you. I guess thinking about treating pets, we have to get the people that are attached to the other end of the leash on board with our treatment plans in order to be able to effectively treat our canine patients. So thinking about that, I'm sure you can probably relate, the number of times I feel like I'm recognizing pain, but I hear, they're not in pain because they're not crying out, or any number of variations of that can create a little bit of a barrier to making sure that the client understands what canine pain looks like and that their dog is indeed painful, and therefore we need to treat. So, how do you approach that, kind of effectively communicating with owners that indeed this is a dog that's painful, even if maybe the changes are a little bit more subtle, or they're not crying out? I'll be honest, the not crying out always gets me, because I'm like, if I was painful, I wouldn't like cry with every step. I would also walk around, relatively normally with a little bit of a change in my gait.
Yep. And it's funny because I feel like this is something that I see every single day in my surgical service. And, you have the three-legged dog that comes to you for its cruciate ligament, and you're talking about, oh, well, what is your pet on for pain right now? And the owner says, well, he's not in pain, as you're watching the dog walk on three legs. And there is a funny, almost reality gap sometimes between owners' perception and the reality. But interestingly enough, when we start looking at chronic osteoarthritis pain, sometimes that pain can even be harder to tease out, because now we're looking at a level of chronicity. Dogs are inherently good at hiding their pain from us already. And so we're not the first ones to kind of have this conversation or even look at it. Actually, Enomoto out of NC State was looking at young dogs specifically and identified that 40% of dogs between the ages of 8 months to 4 years had radiographic evidence of osteoarthritis in at least one limb. We're talking a large number of dogs in the young dog window. And then of those dogs, 24% had, or of the dogs that they looked at, 24% had joint pain. So they were actually painful. What the one part of the study that really just like gets my soul is that only 2 of those dogs were actually getting pain relief. So only 2 of those dogs were actually recognized as being painful. And so I think we almost sometimes have to take a step back and recognize which dogs might actually have pain and broaden our idea of who that might be. I think we tend to kind of put the blinders on and say dogs that are in pain are going to be the old, crunchy dogs only. But we really do need to look at the younger population of dogs. This study tells us that. And if you look at the dogs that I see on my orthopedic surgery service, those are the dogs, right? They're in that age window of 2 to 4 years. Those dogs have radiographic changes based on whatever orthopedic procedure I'm doing on them that has osteoarthritis already, and generally some form of pain associated with it. But I do think that we have to kind of look at veterinary professionals as well, because if we also feel that we aren't confident in recognizing pain our own selves or doing a good orthopedic exam, how are we ever going to be able to not only recognize ourselves, but then convey it to owners? So it really comes back to step 1, which is us as practitioners being really good at our orthopedic exams to be able to say, yes, I have identified pain in this pet, and then going to that next step, which is getting them on board with the level of pain that pet is feeling, and that we really do need to start intervention for them.
Do you have like some kind of quick and dirty tips where, maybe 1 or 2 things that you're going, if in general practice we could do these few things a little bit better, we would do a better job at recognizing pain and being able to make that more confident recommendation?
Yeah, so, and it's funny because again, it comes back to identifying the dogs that need the orthopedic exam. So I'm gonna tell a funny little anecdote here, because I've been in the surgery world pretty much since I graduated vet school, right? I did an internship and then a surgical internship and then surgical residency, and then I practiced as a surgeon. So I lived in a very narrow surgery window, and I spend a lot of time now talking to general practitioners, and I realized I have no idea what their day-to-day life looks like. So I went and did a day of Relief GP about 4 months ago. And hands down, it was the hardest day of my career. I really thought that I was going to go in there and be like, all right, rabies on the right, sign your certificate, off you go, healthy pets and puppies. That's not what it was. I saw 20 appointments. So I had 15-minute appointment slots. I had a little lunch in there. Of those 20 appointments that day, 18 of them were the, oh, by the way. right? So I now am going in to do vaccines on a kitten that, oh, by the way, I go in, it has an upper respiratory infection. I now have a dog that's getting radiographs because, oh, by the way, it's been vomiting for a week. I have the dog next in line for radiographs because, oh, by the way, we have a new heart murmur today and I'm assaulting crackles. So it was not the day I expected it to be. How many orthopedic exams do you think I did that day?
I'm wondering, so I'm picturing the orthopedic exam being just kind of muscle memory as part of your physical exam. So, I mean, that's a lot. There's something in the water lately. That's been like every single one of my patients recently, and I've heard the same thing from multiple colleagues. I'm gonna guess maybe like half of them.
One.
One.
I did an orthopedic
I feel
exam
so much better.
on one patient, and it was a patient that presented for hind limb lameness. So I had that call out to, hey, this pet needs the orthopedic exam. I'm good at them. I pride myself in my orthopedic exam, and I didn't do them. So when I got home at the end of the day and I'm laying on the couch, totally tuckered out from this wild day, which I do not know how general practitioners do this, I was kind of thinking to myself, well, why didn't I? What was my barrier to even doing it? Because I guarantee you there were dogs that I saw that day that had osteoarthritis and I wasn't looking at them. And I'm a surgeon. I should be looking at them. So then I kind of thought to myself, well, what if my team had been able to call to my attention and say, hey, doc, this dog needs an orthopedic exam. And there's definitely some ways to do this, right? So you think about the practice, your typical general practice. Who do you think sees the dog the most?
Oh, definitely the technical staff,
Or the owner.
technicians and oh, sure. Yeah. I was going to say during the
Sometimes I
appointment,
hope it's
they
the
have
owner.
this little window with us and then we have our wonderful technicians who are doing history and vaccines and everything. But yes, I would venture to guess that probably the owner sees the dog
So like
more
owner is probably
than the
number one, but
technician.
within the practice, you're right. It's probably the technicians, right? Unless you're at an ER practice where you have really long wait times, and so
Sure.
the people spend a lot of time up front in the lobby, then it might actually start shifting towards the front desk staff that actually sees the dog the most. But if we can help train those personnel to see dogs and start recognizing some of the important behaviors to just raise that little red flag. That's the big ask. The big ask is just to recognize the dog that needs the orthopedic exam. That technician is going to be the one that goes up to the front lobby. They get the dog, they watch the dog walk, they watch it get on the scale, off the scale, they follow it into the room. When that dog gets in the room, that's probably when it's going to be the most active. It's going to go around, it's going to smell things in the room, it's going to be mobile. After that, it's going to settle in. So the technicians are the ones seeing that. So if they can start to see some things or even ask owners some questions in the history to start sort of probing, just to have it then recognized to the doctor, have that message conveyed that says, hey, I think this dog needs an orthopedic exam today, then I would have done it myself, right? I would have been like, yes, I get to do what I love doing. But it just wasn't forefront of my mind, right? I was so stuck on like, where do we give lepto? Are we still recommending lepto? Is that a thing we do here? And I wasn't even in the mindset of thinking orthopedics. And again, if I was in that situation, how on earth can I sit here on my little surgery pedestal and tell people you need to be doing orthopedic exams on every patient when I didn't do it? So to me, that is truly step one, is recognizing the pets that need the orthopedic exam. Step two is, now that your technician, or heck, sometimes you can even have the owner self-recognize a little bit. Zoetis actually has this really awesome OA checklist. You can do it as a QR code, or you can like print it and laminate it, and the owners can just go through and check a box. Basically, it's got little diagrams of behaviors their pet might be doing at home. The obvious ones, limping, but slowly going up and down stairs, slow to rise. And if you walk in the room and there is a check mark anywhere on that sheet, that dog's getting the orthopedic exam today. Just to have, again, that little red flag that says, all right, somebody told me I need to do the orthopedic exam, whether that was the owner or your technician or your front desk staff. And then step two is, we're now going to do the orthopedic exam, which can be really scary, right? When you're like, oh man, now I have to do it. There's also a funny misconception about the orthopedic exam. People think we're supposed to magically put our hands on the dog's joints and then tell the owner exactly what's wrong with that joint, what it's going to look like on x-rays, and what the long-term prognosis is going to be. That is
Yes,
not
yeah,
the goal.
that's my perception of an orthopedic exam, and it does
And
make
that's
it very
not the goal.
intimidating.
The goal is far simpler than that. The goal is what leg and what joint. That's it. Sometimes it might be multiple, but that's it. That's the whole goal. From there, you can then make your differential list of what might be going on with that leg and that joint. You can then come up with your diagnostic plan. You can take a culminated radiograph to the joint of interest instead of a dogogram because you're not really sure where it's coming from. So that's all the orthopedic exam is. I add in a third little bullet or a third little asterisk to that orthopedic exam that makes it the northopedic exam, where I then say we should also be answering the question, are there any neurologic deficits? We do this all the time in our surgical practice. I kind of take it for granted, but I'm always trying to answer that question for myself of if I make this pet three-legged lame after surgery, how well is it going to handle walking on three legs? So that component I have to answer is, do we have neurologic deficits? So all of us surgeons were doing it, we just weren't really thinking much of it. Don't get me wrong. I was not doing all of the cranial nerves and recording all of that, but what was I looking at? I'm looking at neck range of motion, palpating cervical spine. Remember, you're going to palpate C6, C7 down low in front of the shoulders, palpating spine for discomfort, checking for CP deficits, and hopping each foot, like all four of the limbs. Just answer that question. Are there neurologic deficits? Because once you have that, you now know what leg, what joint, and are there neurologic deficits? And then you can go from there.
Sure. And, I had that conversation with someone recently where they explained it exactly the way you did to say, what limb, what joint, narrow it down to a joint or two, and then create your differentials. And it does make it much more digestible. And I love the idea of checking for neurologic deficits because yeah, I could see getting very focused in on like this is, for example, a limping dog, and this is an orthopedic issue. We do an orthopedic exam, and forgetting the neurologic components there, and so calling it an orthopedic exam is kind of it seems like an easy way to think about it to go, oh yeah, remember to check for neurologic deficits. Even still, sometimes so let's say we get very comfortable with our orthopedic exam. Some of these signs of pain can remain subtle where we can pick up on this because we have a different understanding of animal behavior and we're dealing with animals day in and day out and spending our free time learning about this because we're all nerds and love it. But still, if we don't have a pet who's crying out in pain or obviously limping, we can struggle with communicating this to the owner. And so thinking about this in terms of chronic pain, especially like predisposed breeds to osteoarthritis, how do we, maybe we kind of pick up on this predisposition to joint disease and what will eventually turn into chronic pain in a patient who is not really clinical yet or, just very, very minimal signs of pain. Sometimes I find that when I'm talking to owners about this, I may have just gone to like a whole different talking point in my head, and I may come back to the first one, but now my brain has gone somewhere different. So I'm gonna go with it. When I'm talking to owners about this, when I'm thinking of like chronic pain and predisposed breeds, and I may pick up on signs of osteoarthritis that in a patient that maybe isn't necessarily clinical, I find that if I start that conversation with the owner, in that context, they may not be on board because they aren't picking up on anything at home. But still starting the conversation can support me when in a year from now, come back for an annual exam and the signs are a little more pronounced. Maybe I can pick up on more pronounced clinical signs as well as things on my orthopedic exam. So I call it planting the seed. I do this with like dentistry and things too. We're starting to get a little bit of tartar, so that at some point when I'm like, all right, it's dental time, this isn't the first time the owner has heard me talk about their pet's teeth. Can you talk about how we kind of plant the seed with owners where we have a dog who's maybe only mildly affected or just predisposed so that we set this dog up for appropriate management down the line? That was a really roundabout way to get there, but I hope I got there by the end of the question.
And I totally understand the whole planting the seed, because psychologically, as humans, sometimes it takes hearing something multiple times for it to actually hit home. Mm-hmm. Same with learning, right? When we're learning new things, sometimes you have to hear it enough times for it to become something that actually stays in your brain. So honestly, I start very early with my education with clients talking about osteoarthritis. like as early as puppy vaccine appointments, which thankfully, as a surgeon, I don't see many of them. But when I am seeing puppies as a surgeon, I'm generally seeing them for a condition that is going to lend itself to long-term osteoarthritis. Hands down, there are no ifs, ands, or buts, right? We're talking about the elbow dysplasia dogs, the hip dysplasia dogs, that they might not be clinical at that moment, but they are absolutely predisposed to the development of that. So if you can start that conversation early and say, hey, this is what you need to watch for in your dog, then hopefully you're actually going to have them be able to flag earlier that their pet is affected. And I've actually had owners come to me even sooner than they probably would have if we hadn't have talked about it earlier, saying, hey, remember when we talked about watching for, being a little slower to stand or maybe hesitating at the stairs? I'm starting to see that. And as soon as they are, like, we know now's the time we need to start intervening. I'll take this in terms of my very surgical brain, right? So think about our TPLOs, right? These are probably my most common orthopedic surgical case. When I look at radiographs for a TPLO, or even when a radiologist looks at them, what are they looking at on that radiograph to tell you that this pet has a cranial cruciate ligament disruption?
And we're looking for stifle effusion, I think is the first place my brain goes.
Yep.
And then
And then
certainly,
so
if
like
we do
shifting
have.
of the fat pads, like those soft tissue changes. But then another big criteria is the location of the osteophytes. And what
Sure.
are osteophytes? It's arthritis.
Yes, yes, yes. This is okay. I'm
So,
with
so
you. I'm with you.
on day one that I see that pet, they already have osteoarthritis. Yeah, sometimes you get a very acute cruciate and they haven't quite developed their osteophytes yet radiographically, but I know they're going to, and generally by the time you do your follow-up radiograph, somewhere between that 8 to 12 week mark postoperatively, they have the development of osteophytes. Because we can say definitively that that is osteoarthritis, I can already say these pets have it. So on day one, when I see them for their TPLO appointment and we are talking about surgery, I'm already talking about the long-term plan for them. I'm saying, hey, I can stabilize your pet's joint. I can make it feel a lot better. Heck, we might get to go years before we need to start thinking about what our long-term plan is going to be. But here's what I want you to look for in your dog that tells us that now that osteoarthritis is catching up with us, because I can't stop it, I can't reverse it, I can't cure it. All I can do is my best management to slow it down, which at that time is likely doing our TPLO procedure and then monitoring and intervening once we start to see those clinical signs. But if I can plant that seed on day one, I'm going to get those owners coming back to me sooner when they're starting to notice those subtle changes we already talked about. And then we can say, okay, now we need to initiate our pain management plan. And that really is where I start. I start with analgesics first because I need to get the pet as functional as possible as soon as I can.
Sure, sure. Yeah, going after the pain, the thing that's slowing this animal down. Going back to your day in general practice, which I really appreciate the shout out. I'm not even full time in general practice, and yeah, like sometimes I get to the end of the day and I have no idea what just happened and if I actually gave anybody the correct advice. I mean, as you can imagine, these are conversations that need to be had early and often, but there's a lot to talk about because one, we're thinking of just even in a healthy appointment, we have vaccines, we have heartworm prevention, spay neuter status, nutrition, things along those lines. And then the owner is also absorbing a lot of information. So sometimes if we start to talk about you have a Labrador, and most likely we're going to be looking at some degree of arthritis in some way, shape, or form down the road, we may not have time to say it, and even if we do, the owner may not absorb it. So I want to talk for a minute about opportunities to get this message out and plant that seed and make sure that owners are aware that they should be on the lookout for these types of things outside of that single appointment. I think that's one thing I'm appreciating more and more is with the rapid advancement we've seen in vet med, there's so much to talk about because there's so much that we can recognize and intervene on that sometimes it's like, what do I prioritize? And this is why I'm always running behind in appointments, is because I don't like to leave information on the table. I'm like, but I have this information and I could talk to you about it. But realistically, sometimes we just can't with all that there is to cover in an appointment. So do you have thoughts, ideas for making sure that we're reinforcing this message outside of an annual exam?
Yeah. So I think that we also need to recognize just a little bit that many clients actually do crave education. How many times do you hear clients say, "Oh, I wanted to go to vet school," right? It's because they want to know as much as we know about animals. And that if we can kind of say, hey, yeah, they do want to know things, and we provide education for them, they will gravitate to it quite readily. So there are a couple means that we can do this by. So social media is a huge and relatively easy one. So this is one that even your own practice can do. Zoetis actually has a number of resources available, both email campaigns that hospitals can personalize, but we also offer social media posts that hospitals can then share to their own profiles. The goal here is that, yes, Zoetis makes medications, but the goal is to actually support kind of the whole journey because, again, client education is such a huge component of it. So if that's something that a hospital would be interested in, all they need to do is reach out to their Zoetis rep to explore what those options are. But the nice thing is when you think about what clients are doing most of the time, even when they're sitting in the room in between the tech getting the history and the doctor coming in, they're probably scrolling their phone. Right? That is what everybody does nowadays. So if there can be education available to them, and sometimes hospitals are going to have a dedicated social media person, but if you don't, that's why we have made those resources for hospitals to tap into. And heck, even your social media person can tap into those for you to be able to get that education out there. And we have plenty of it. And sometimes clients are going to go seek that on their own, so making it readily available. I think that also bolsters the relationship between the client and the hospital because clients love to follow their hospitals on social media. They love to see posts of cases. They love to follow up. They're always secretly hoping it's going to be their dog one day, right? And so I just think that having that social media presence can not only help bolster the relationship, but also provide the education.
Sure, sure. So kind of leaning into our resources to provide education for clients through social media, obviously a great outlet, clinic websites and things. And it sounds like you're talking about almost a mindset shift to say, to assume that clients are going to be seeking out this information in between appointments and make good, relevant, accurate information available to them through multiple channels.
Yeah, especially when there's so much misinformation so readily
Sure.
available in the world. I feel like it's almost our obligation as a profession to try to provide the best possible factual education that we can for them and give them that resource to go to that they know is going to be validated information, right? When they say, I got this from my veterinary office, it's different than, oh, I read about this somewhere on Google, blah, 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 right? So it gives them that safe source of confident education. And you would be shocked how much, I mean, I have hour-long appointments as a surgeon. 40 minutes of that appointment is client education, and they love it. They love to learn as much as we can teach them. Even for people who seem disinterested, they're always in the end saying, wow, I'm really glad you taught me that, and I understand what you're going to do with my dog now. So again, never undervalue how much education clients crave.
Sure, sure. I think you really hit on something there that now I understand what you're doing with my dog, like why we're making the recommendations that we are, rather than I just don't think we're in a trust me, I'm the doctor type of situation in most cases. And so being able to sit down and explain things to people as much as we can, hour-long appointments are like my dream. That sounds amazing, but not always a reality in general practice. But I like what you're saying about putting that information out there through multiple sources, because then it can help foster that conversation in the exam room where it might not be something that is top of mind for us because we're focused on something else during that appointment, but maybe cues the owner in to ask that question and say, hey, I was reading about this, and I'm curious about this in my own pet. We're all looking out for that pet, us as the veterinary team, and then the owner at home kind of has some ideas of what they're looking for going into it.
Yeah. It goes back to your whole planting the seed idea, right? That if you can give them some education on what pain might look like in pets, then you know they're going to be the ones that's seeing their pet the most. They're going to be looking for their pet, watching for those things, and then be more likely to bring that concern to you organically instead of us needing to constantly dig through in our short appointments and figure out that that's what's going on with the pet.
Yeah, I mean, it sounds like there's the time constraints in general practice. They are what they are, and we'll continue to navigate those in however we can. But part of what I feel like we're talking about here is just missing out on a huge resource to be part of that care team in terms of not feeling like we have to squeeze all the information into one appointment, but really tapping into the owner there and saying, hey, we need you to be just as much a part of this as we are and bring your concerns to us. So we're not trying to tell you everything in a once a year conversation. If we can jump forward, let's say, to, you mentioned TPLO dogs, a pet who is showing obvious clinical signs. I think that sometimes is yeah, where the orthopedic exam gets very intimidating when we know this pet is showing outward clinical signs. And yes, I certainly have been known to go in and go, oh gosh, this is really intimidating. I have to give you a diagnosis and tell you exactly how this is going to go. But knowing now, having the relief of knowing that that is not the goal of our orthopedic exam, how do we communicate our findings to the owner in a way that kind of gets them on board with what we're seeing clinically and that we need to take some form of next step, whether it's radiographs or pain medications or whatever it may be?
Yeah, so I think that as a veterinary profession, and then I'll talk about surgeons specifically, but as a veterinary profession, we can have a tendency to be a little bit wishy-washy in our recommendations, that sometimes we're just listing all of the options for them. But realistically, I feel like we need to kind of put on our surgeon pants a little bit sometimes and pretend to be a surgeon. Put that hat on and walk in the room like you are that confident surgeon who's going to go in there and say, I recommend this. I recommend, like, here's the reason why, but actually using that word and saying, this is my recommendation. Here is my why. Because when we're just giving a list of options, and we're not being confident in what we really do believe is the like gold standard option, we're saying, oh, we could maybe do this or we could maybe do that, then they're obviously going to sometimes lean towards the cheapest option, lean towards the waiting, right? We so often end up in a situation with pain management where we're waiting on it. You would never do a spay and recommend not doing pain management. Yet when we're faced with osteoarthritis pain, we have a tendency to either forego or delay the pain management, and we can accidentally make it optional. It shouldn't be option. This is a chronic progressive disease. It's not going to be cured. It's not going to be reversed. It's not going to be stopped. So we have an obligation to prioritize appropriate analgesia, to walk in that room and say, here's what I have diagnosed on your dog. This is my finding. I recommend this. That might be recommending a specific diagnostic to feel like certain in our conclusion of that, especially if you have multiple differentials that you're like, I really need to know for sure before I can make my next step recommendation. But if you are also feeling very definitive and you're ready to make that recommendation of analgesia, make the recommendation, right? Walk in that room and say, I recommend that we start a pain management plan for your pet. Once they hear that, they want to know what the veterinarian recommends. That's why they've come to you, and being wishy-washy and saying, oh, well, we could start with some supplements and see how it goes, and then step up to the other therapies. Well, now we're working backwards in appropriate pain management. When you look at osteoarthritis as a condition, and generally we're speaking about the chronic pain version of osteoarthritis, we tend to work backwards and start with the easier supplemental conditions, but we have pets that are muscle atrophied. Our goal is sometimes to do weight loss for them. So we want to be doing exercise for them. Sometimes we want to be sending them to physical therapy. Those are all things you cannot do until you have a pet that is comfortable enough to do them. So all those other steps of pain management, you can't even start to do until you've started your analgesic plan. So saying it strong, walking in that room, put on your surgeon pants for just a little bit and say, I recommend this, right? And being confident in that is going to help the owner be confident in your decisions as well.
Absolutely. I feel like that can be applied across so many clinical scenarios. It's always such a good reminder because, yeah, I think it is easier to feel like we're hedging a little to say, are you okay with this? And part of it comes from, we see all sorts of different situations between clients and patients. And so trying to figure out what exactly is in front of us and how we're going to approach this going forward. But I think that's such good advice to just be direct and just ask the questions, make the recommendations, and put our surgeon pants on for a minute. I love it. How do you approach analgesia in these cases? What's your kind of go-to?
Things we already kind of talked about today is when I'm starting to implement the plan is, of course, going through it in a stepwise fashion. So I always start by discussing osteoarthritis pain early. Sometimes the very first time I'm ever seeing that pet, we are going to talk about osteoarthritis, whether they have it or not, because I want to plant that seed of what to look for. From there, step 2 is going to be doing my orthopedic exam on that pet, answering those questions. What leg, what joint, are there neurologic deficits? And then I have a very unique benefit as a surgeon in my practice that I'm almost always going to be able to confirm that diagnosis with radiographs. If pets are not coming to me with radiographs already, they're already planning to take those radiographs that day. That's what they're set up for. So again, I know that that's a unique benefit that I have as a surgeon. But then my reminder is that if you don't feel confident in your diagnosis or you want to just be absolutely certain in what you're treating, then go ahead and confirm that diagnosis with radiographs. That's why we have that diagnostic tool. Then the next step is going to be actually implementing my analgesic plan for the pet. There is so much we are required to do or expected to do for osteoarthritis pain management, right? We're supposed to weight manage the pet, which means we need to get the pet exercising. We should be referring them for physical therapy. There's just all of these check mark things we're supposed to be doing, but we can't even start to do most of those things on that list until we have a pet that's comfortable enough to do it. So really, step 1 is picking your analgesic plan for that pet so that you can get them comfortable, so you can get them walking again, so you can do your weight loss for them. And so if you actually look at the published guidelines that are out there, so the AHA Pain Management Guidelines published in 2022 actually lists an anti-NGF monoclonal antibody as an option for first-tier therapy, along with NSAIDs for the control of chronic osteoarthritis pain. So they broke it down into tiers. There's tier 1, tier 2, tier 3 as far as therapy goes. And I think that even I, in my own practice, I was working backwards through this for a long time and kind of starting with the supplements, starting with the easier therapies that maybe weren't going to be quite as efficacious, but hey, they were cheaper. Sometimes, if you look at the long term, it probably isn't. But when you look at the AHA pain management guidelines, it really encourages us to work forward, starting with our most validated appropriate analgesics first. That's going to be a monoclonal antibody or an NSAID. So then if I'm going to be picking a monoclonal antibody versus an NSAID, it's going to be very pet dependent and owner dependent because we are looking at compliance for administration of medication at home, availability of that owner to bring a pet back to the practice to get a monthly injection if we're going that route. So when I'm going to be picking an NSAID therapy specifically, so I need chronicity of therapy. I'm talking to them about giving it every single day. And we actually have a beautiful study that has looked at this for us. It was administration of carprofen at a 4.4 mg per kg dose once a day for 120 days. What they were kind of expecting to see in this study is that they would see an improvement in lameness scores and they'd be able to sustain it throughout that study with the continued administration. What they actually found is that the pet's lameness scores got better and better and better throughout that entire 120-day duration, which speaks volumes to the fact that if you have a chronic condition, you need chronic therapy. You can actually see it get better when you're appropriately pain managing them every single day. Unfortunately, and I'm guilty of this in my own practice, sometimes we don't use it that way. Sometimes when we're prescribing NSAIDs, we're saying, hey, when you see your pet limp, go ahead and give it. But then we're getting peaks and troughs in our therapy, right? We're getting a dog whose lameness scores inherently get worse, and then we give them medication, they get better. And their lameness scores get worse, we give them medication, they get better. And we're really kind of not sustaining the therapy for them that's going to get that continued benefit. If I am implementing a monoclonal antibody like Librela for these patients, then I'm going to be setting them up for a 2 to 3 dose commitment. We did this in our practice by offering a discount if you signed up for the 3-dose package, which saved you in total $9. Which I did this for my own pet, and I laugh at myself now because I was like, I saved money. But again, how many times do you buy something just because it's on sale? What that also did is it signed me up for that 3-dose commitment, and it pre-scheduled those appointments for me so that I knew that I needed to bring my dog in to get her injection. You'll be more likely as a human to reschedule an appointment that is already on the books than you will be to call in and schedule something organically just because you got a text telling you to do so. So pre-booking appointments can have a bunch of utility in implementing these chronic therapies. We can also, so we know that this drug can take up to 2 months to reach steady state. And that's really why I want to get that 2 to 3 dose commitment so that we can capture the maximum number of dogs that are going to see that efficacy happen in that time period. From there, we also need to make sure, I don't care if you're picking an NSAID or a monoclonal antibody, chronic pain management is not a set it and forget it plan. You don't just send them their prescription and say, see ya when I see you, let me know if something else happens with your dog. No, we really do need to be setting follow-up for these patients. At minimum, at 6 months, I want to be doing my orthopedic exam again on that dog. If I found something more worrisome at my first exam, I might actually be doing a bit more frequent follow-ups with that dog. When I'm initiating my plan, sometimes I do want to see them at month 1, month 2, and month 3 to see how they're responding and repeat my orthopedic exam, and then setting those actual follow-ups so that we can check in. Unfortunately, osteoarthritis is a chronic progressive disease. It's going to get worse, no matter what interventions we are implementing. And so as we start to see progression of that condition, absolutely, we might need to add in more things to be more multimodal in our therapies. Things I might also be adding in, I love gabapentin. I love amantadine. I love fish oil. Actually, the omega-3 fatty acids are what we have the most evidence for from a publication standpoint for validation of its efficacy. So absolutely, I'm going to lean into those right away if I can. If I can either prescribe a diet that has it in it or a supplement, and you can actually go to CSU has a website where you can calculate the appropriate dose of omega-3 fatty acids for a patient based on weight to be able to get the appropriate concentrations needed to see change in orthopedic disease.
Yes, I have used that website, and people are always surprised when it comes to osteoarthritis and really like how much we have to give these dogs in terms of omega-3s. And I'm like, it's a much higher dose than
It's a
we reach
lot.
for
I
in
used
other
I used to
conditions.
tell people just like quadruple whatever the dose is on the bottle. But when you actually do the calculation, you would be shocked that how often it might be even more than quadrupling the dose just to get the appropriate amount.
Yes, yeah, I believe it. And that helps head off the people who come back and then say, it's not working. You're like, well, we're not giving enough. You have to give a lot for osteoarthritis. Oh, that is a good rule of thumb, though, to quadruple things. No, I love that approach in terms of making sure. I think you made some really good points there. Chronic disease, chronic therapy, making sure that we are treating appropriately with pain medications so that then we can implement the weight loss and the physical therapy and the other pieces of the plan that are going to make this a long-term plan. I'm curious, kind of as we wrap up here, when you're talking about using an anti-NGF monoclonal antibody, do you get pushback from owners at all? How do you navigate the conversation around will there be side effects or anything along those lines?
Yeah, and it's so funny because I feel like I've been handling this conversation with clients with NSAIDs for my entire career, and the conversation really hasn't changed that much because like any other medication, there's always a risk of adverse events. If we're looking at the kind of statistics out there, currently there have been more than 33 million doses that have been distributed worldwide, and even the most often reported adverse events continue to be reported rarely or very rarely. That reporting rate is a 0.01 to 0.1% rate. So every time a dog is given Librela, there is a really convenient client information sheet that should be given to them and discussed with owners at the time, anytime we're administering Librela. And it can give them a nice overview of things to look for at home, when to contact the veterinarian, and any other concerns that they might have are listed in that. And so that can make your lives a lot easier as well.
Sure. Yeah. And just, I like that idea of making sure that kind of all the information is contained. And then, yeah, I did not realize the reporting rate of adverse effects and things. And you're right. Like I've certainly had this conversation surrounding NSAIDs as well. So all good information to kind of start that conversation if clients were to bring it up. Dr. Malin, this has been a great conversation. I feel like it's a conversation that bears having in multiple different contexts because like kind of like you pointed out at the beginning of the conversation, we know that young dogs are dealing with signs of osteoarthritis and that we need to start talking about chronic pain management, acute and chronic pain management early with pet owners. But it can feel a little bit intimidating when we're going about that exam and giving the pet owners that information. So this has been hugely helpful. I really appreciate the conversation. Are there any final thoughts you want to leave us with?
Generally speaking, sometimes what owners are seeing in their pet at home might not be recognized as pain. And the biggest thing we tend to see is actually behavior changes. Behavior changes have been recognized in humans as a sequela of chronic pain. And so if we extrapolate from that information and that research, that would absolutely tell us it's probably the same in dogs. I am absolutely not convinced that every little dog is born a land shark, but I know that many little dogs have underdiagnosed orthopedic pain, right? How many little dogs come to me because their femoral heads don't live in the same zip code as their acetabulum, or their grade 4 MPLs are now so bad that their hind limbs are physically crippled, but you just wouldn't know it because they're purse pets, right? Their feet never touch the ground. And so we really do need to look at behavior changes in pets as being that signal to us that, hey, something has changed and pain needs to be on that list. That holds true for big dogs, right? Sometimes big dogs can develop, for instance, an aversion to children, right? Because children, specifically the small toddler ones, have a propensity to lean on pets. And that a kind of acute leaning can cause a pretty profound pain response that can make them very averse to children very quickly. So, anytime you're hearing, was great being picked up, but now we're not, was great with kids, and now we're not, like that should really be a red flag to say, hey, we need to do an orthopedic exam on this dog. Obviously, like this is one of my, like when you really start to think about it, think about that happy, slappy, dumb golden retriever that for the first 3 years of its life was just absolutely nuts and wild. And then around 3, just chills out. So if you actually start looking at a behavior change like that, many people just think, oh, we're just settling down. But I really do think in those cases, you should probably check that box and make sure that they're not just responding to orthopedic pain and wanting to be less active secondary to that. So again, really looking at behavior changes in pets and then trying to make sure that we're ruling out that differential of pain for them.
Yes, I love that. It makes me think of my own dog, where and kind of an argument for making sure that we're really advocating for our patients if we feel like we're detecting pain. Because I know with my own dog, he has IVDD and he'll tweak his neck every now and again. And the first time, I really leaned into treating him, and it got pretty bad. We did all the things, and he turned into a different dog. And I'm a veterinarian. Like I know what to look for. I know how to assess pain in my dog. And even I was maybe not quite as aware, maybe I was in denial of them, of the more subtle signs of pain that he was exhibiting. And then when that pain got bad and we really got very serious about treating, it was very multimodal. And then I saw the change in him. As soon as that starts to flare again, I'm on top of it and managing that completely differently. So yes, and it was a subtle behavior change with him. He wasn't walking around crying out. His gait didn't even necessarily change. But when I saw his behavior go back to normal, yeah, he wasn't supposed to be chilling out. He was supposed to be, he's an English lab, so he is still kind of a potato. He's pretty chill, but he not as chill as he was acting.
Yeah, but absolutely. I do think that observing behavior and talking to owners about what sort of behaviors their dog has at home can really tie into whether or not they're experiencing chronic pain.
Sure. I love it. Yes, let's keep these dogs happy and moving and wild and comfortable for as long as we possibly can.
Yeah, so overall, I just feel like in kind of a conclusion here is that we really need to remember that early intervention leads to more positive outcomes. And it's funny because I've said as long as I've been in veterinary medicine that age is not a disease. But I think youth is also not an excuse, that we need to be sure that we are screening all dogs and really having our team help us identify dogs that need orthopedic exams, feeling confident in doing our orthopedic exam, and then making confident recommendations for appropriate analgesic management in these dogs.
Thank you so much again for the conversation. I really enjoyed it, learned a lot. Thank you.
Yeah, thank you for having me. This was a fun, eye-opening experience.
Yeah, same. Yeah, I took away a lot from it. Thank you so much, everyone, for tuning into this episode. I hope you enjoyed it and found some good takeaways for kind of this long-term approach to managing osteoarthritis and how to recognize these patients and do our best to take full advantage of the opportunity to manage joint pain early in our patients. I want to say a big thank you to Zoetis for making this episode possible. Thank you to Dr. Malin for joining me. Of course, thank you to each and every one of you who tuned in and listened to this episode. If you enjoyed it, please, would you leave us a 5-star review wherever you get your episode? It'll help other veterinary professionals out there find this episode and find other great content that we are working diligently to try to put out there for you. If you want to find more episodes, you can find them under the Education tab on the VetFolio website or wherever you get your podcasts. If you have thoughts on this episode, please reach out. I want to hear them. I'd also love to hear ideas for topics you'd like us to cover in the future. Certainly, when you send those emails to dvm@vetfolio.com or reach out to me via Facebook at Dr. Cassie DVM or Instagram at dr.cassie.dvm. I do get those messages, I see them, and some of our episodes that we have produced have actually come from those ideas that people send in. So I would absolutely love it if you want to reach out and let us know what your ideas are, what your thoughts are. We want to make the episodes that you want to hear. And of course, remember, if one animal is better off because of you today, it's a great day. Librela Important Safety Information. Librela is for use in dogs only. Women who are pregnant, trying to conceive, or breastfeeding should take extreme care to avoid self-injection. Hypersensitivity reactions, including anaphylaxis, could potentially occur with self-injection. Librela should not be used in breeding, pregnant, or lactating dogs. Librela should not be administered to dogs with known hypersensitivity to bed-and-vetmab. Adverse events reported post-approval include ataxia, lack of balance and coordination, anorexia, loss of appetite, lethargy, tiredness, emesis, vomiting, and polydipsia, increased drinking. The most common adverse events reported in a clinical study were urinary tract infections, bacterial skin infections, and dermatitis, skin irritation and inflammation. For more complete safety information, refer to the full prescribing information at librelapi.com.